Hi guys, so this is the physiology review for George Papadakis. There was no self-study material for this. This will be relatively short. I'm just going to take you through the exercises that were in the CBCL that I had anything to do with. This first question was technically from Ann Hartley, but I helped out with it, and I certainly did most of the explaining to most of the small groups on it. So you were assigned the task of matching the pressure volume loops with the valvular disease, and the choices were mitral regurgitation and stenosis, what I was calling mitral insufficiency and stenosis, and aortic regurgitation or insufficiency and aortic stenosis. So the first one of these loops was actually mitral regurgitation, and the most common question that I got was how to tell this from aortic regurgitation, because these two loops look very similar. The volumes are very high, and that's because the preload is high in both cases for different reasons. In the case of mitral regurgitation, what you're doing is you're ejecting blood back into the atrium, and when the mitral valve reopens, that blood that was ejected into the atrium comes back into the ventricle along with what you would have normally had come in. So that increases the filling quite a bit, and your preload goes up very high. In the case of aortic regurgitation, what's happening is blood is flowing from the aorta back through the insufficient valve during filling, and so you've got normal filling going on through the mitral valve, and in addition to that, you have blood coming into the ventricle through the aortic valve, and that results in a higher preload. So the way to differentiate between these two, there are actually two things that I would look at. The first one is this isovolumetric contraction component. So ordinarily A to B, isovolumetric contraction, because your pressure is going up, your volume is not changing because both valves are closed. Well, in this case, both valves are closed with mitral regurgitation, but one of them is still allowing blood through. And you know in this case that it's the mitral valve, because as the pressure in the ventricle rises, and certainly it exceeds the atrial pressure as you ordinarily at A, the mitral valve closes as you exceed atrial pressure. So as you exceed atrial pressure, you lose volume. And so from A to B, you've actually lost volume in this loop. And during the ejection phase, instead of being isovolumetric straight up, you've actually lost volume, and B is at a lower volume because you've ejected blood not only into the aorta, or your pressure has risen, and ordinarily where you'd have no volume changes, you're actually losing volume through the mitral valve. In the case of aortic regurgitation, the same thing, ordinarily isovolumetric, but notice in this case you gain volume, and that's because blood is flowing from high pressure to low pressure. The pressure in the aorta is higher than the ventricle. Now the ventricular pressure is rising during isovolumetric contraction, but it's still lower than the aortic pressure. And so the blood is flowing from the aorta into the ventricle during this period instead of being isovolumetric. So you gain volume, and your volume is higher here rather than lower. The other thing that you might look at during the ejection phase in a mitral regurgitation, you're ejecting blood not only into the aorta, but also into this nice low pressure atrium through the insufficient mitral valve. So your stroke volume is pretty high, and you end up with a reasonably low stroke volume. Now it's still higher than, or a reasonably low end systolic pressure and reasonably low volume, actually, end systolic volume here. Now it's still higher than the normal end systolic volume, which would be C, but if you compare that to aortic regurgitation, the aortic regurgitation is almost at 100 here, so it's The stroke volume, when your stroke ends at end systole, your end systolic volume is almost at 100, whereas here it's more like, I don't know, 75, something like that. It looks a little lower to me. So if you're given a normal curve and you want to know which one is which, one thing you might do is look at which one ended up at the lower end systolic volume. That's probably the mitral regurgitation. For mitral stenosis, because the mitral valve is narrowed, blood is still flowing in through it when it's open, but your preload is down because not as much blood makes it in. And so you end up with a lower preload, a little bit of a lower force of contraction, and a much lower stroke volume. For aortic stenosis, remember this is essentially equivalent to an increase in afterload. So what you're doing is you're generating much higher pressures because your preload is higher, and because you have to generate higher pressures in order to exceed that pressure in the aorta. So what's going on here is a little bit of homeometric autoregulation. Remember, if your aortic valve if you've got high afterload, your stroke volume is reduced. That leaves you with a higher end systolic volume. That means that after normal filling, you've got a higher end diastolic volume here, which means you've got a higher preload. You generate more pressure and exceed that aortic pressure, and then you've got your stroke volume here. So as opposed to the mitral stenosis, you actually have a little bit of a higher preload because of the homeometric autoregulation that's going on, okay? And of course, you're generating pretty high pressures because you've got a stenosed aortic valve, all right? I asked this question because I think ordinarily it kind of puzzles students, and I wonder, how many actually think about it. We tell you up front, I told you in the very first lesson, that the cardiac output is the same in both sides of the heart. And that is true. At steady state, it must be true in your heart and any patient that you have. And yet, we say somebody has left-sided heart failure, so how can you have less stroke volume on the left and heart failure, and yet cardiac output has to be the same on both sides. So ultimately the stroke volume is the same on both sides, even though we call it left-sided heart failure. And here's how that comes about. If you have a normal stroke volume on the right side and a reduced stroke volume on the left, you get a lower cardiac output on the left. And that means that the normal stroke volume on the right is actually pumping more blood into the lungs than you're removing on the left side. So you get more blood pumped into the lungs than pumped out. And what that does is it increases the vascular volume and pressure. So your left-sided failure, your reduced stroke volume on the left side, causes an increased pulmonary vascular volume. That does two things. It increases the preload on the left side because you've increased your venous pressures, your left atrial pressure, you've increased filling, you've increased preload, and that increases the stroke volume on the left side where your failure is. You're also increasing afterload on the right side, and that decreases stroke volume and decreases cardiac output on the right. So the more vascular volume you have, the more decrease you have here, the more increase you have here, and eventually the two cardiac outputs come together again, where the left side goes up, the right side goes down, and eventually they're equal again. And that's how you get equal cardiac outputs on the left and the right. Now, the second part of this problem had to do with why you typically get more fluid accumulation in the lungs, why you get signs of left-sided heart failure in the lungs, and why when you see pulmonary hypertension, you should be really thinking left-sided heart failure. And the reason is simply because of this. When you increase the pulmonary vascular volume as a result of left-sided heart failure, you increase pulmonary capillary pressure, you increase filtration relative to reabsorption, and you increase edema, and basically you get pulmonary hypertension in the lungs. This is also why the veins tend to be more visible on a congestive heart failure, left-sided heart failure radiograph. So the fact that these two things have to be equal, and the fact that the left side has to go up and the right side has to go down, and the fact that that happens through this increased vascular volume is the reason why you get pulmonary hypertension with left-sided failure. Now, don't get me wrong, all the other stuff that we've talked about in the past is also going on. Your kidneys are retaining fluid, and your venous pressure is going up, your vascular function curve is still operating, and all that stuff is still going on. And so you'll get increased capillary pressures in the system as well. And sometimes you may see some signs of right-sided heart failure as well, like jugular venous distension or something. But if it's one side or the other, then these symptoms will be, or these signs will be more severe in one spot or the other. If you're getting pulmonary edema, you may still see some, a little bit of signs here and there of right-sided failure, but you should be thinking 95% of the time when you see this, left-sided. When you see in a question stem things like lower leg edema, ascites, the jugular venous dissection, when you see a lot of that, then you should be thinking right-sided heart failure, because exactly the opposite thing is going on. If it's right-sided, in that case, you get more vascular volume in the system, and your preload will go up on the right, your afterload will go up on the left, and they'll come together. And you'll end up with the signs of right-sided heart failure instead of the signs of left-sided. Okay? This was really more Dr. Berderic's question, but I thought I'd go ahead and give you some input on it. He wanted to know what digoxin would do to this pressure volume loop. It will decrease the preload. So if this is George Papadakis, this A prime, B prime will shift downward like here. And what will happen is you'll have less preload, your stroke volume will fall, and you'll still end up on this end systolic pressure volume line, but you'll end up lower down. Now, we give digoxin to reduce edema. So in George Papadakis' case, we're giving it to him so he can breathe. We got to get rid of the fluid in the lungs. So digoxin's a good thing in that respect, but you should be aware of the fact that you need to be careful with the dosage, because you're also decreasing the cardiac output when you do this by decreasing the preload. And so you don't want to give too much of it, or you'll cause a bigger problem with the heart than already exists, in an effort to get that fluid out of the lungs. Okay, that's it. Thank you for your attention.